I did a test run of this last night and I ran way over time, so I'm going to try to condense this a little bit. I did throw in a bunch of questions at the end just for some kind of application for us as like practice questions for some of the higher yield stuff. So if there's anyone who doesn't know me, I'm Kevin. I'm one of the four sports med fellows. I'm giving a lecture today on dive medicine. So I think a lot of us aren't going to encounter a lot of dive medicine unless you're in a part of the world or country where you're going to see a lot of divers in particular. This is something you might not see a lot of, but it is primed for like one or two questions on the CAQ. And I think it is kind of a little bit more of a niche activity in sports. So it was pretty interesting to learn all about dive medicine as I was making this. And so I tried to pack a lot of stuff into these slides, and there are some extra graphics and stuff you guys can look at later when the slides go out, just for reference. But I tried to include a little bit of everything just to kind of cover diving as a whole, in case this is the only big dive lecture you get for quite a while. So, diving going back, I mean, back in the day, it really started as just primitive diving. People used to hold their breath, dive underwater, collect shellfish, sponges, pearls, that sort of stuff. And then we moved into kind of the 16th century when this concept of a diving bell got created. And so, kind of like putting an upside down cup in water, that water pressure traps the oxygen in the air. And so that was the way people were able to dive for a short period of time. I don't know what Sandy and SpongeBob are doing here, maybe making their own little diving bell, but needless to say, this was still pretty primitive in the world of diving. And then came along this hydrostatic machine where someone decided to connect a couple of tubes, one for inhalation, one for exhalation. This lets you dive for 5-minute dive. So that was a pretty big advancement. And then eventually a couple of folks decided to create this pulley system with balance weights. Unfortunately, the two guys who created this actually suffocated and died while diving. So that was a little bit ironic, but nonetheless, they did help advance diving. And then came along this one guy, actually a couple guys who created this concept called the aqua lung. So this was the first real like clinical apparatus that allowed you to breathe gas underwater. And this ultimately led to the development of the scuba. So U.S. Major Christian Lambertson created the scuba in the 1950s, patented this apparatus. So scuba stands for self-contained underwater breathing apparatus. And this ended up becoming kind of the generic English word for diving as a whole and the equipment that we use. There's different types of circuits, so closed and open circuits. Closed circuits use this rebreather that lets you basically kind of recycle the gas and filter out the carbon dioxide. And then you have open circuits with a regulator, and so you'll breathe in the gas and then kind of exhale the CO2 into the water. There are different types of diving, so here are kind of some of the more common types. Probably the ones you're most familiar with are scuba diving. There's free diving, which is actually a competitive extreme sport, and then snorkeling as well. Looking into scuba diving epidemiology, so there's about 2.5 to 3 million scuba divers in the U.S. every year, about 6 million estimated worldwide. So us folks in the U.S. do make up a good population of them. There are about 80 deaths in the U.S. and Canada each year from scuba diving related issues. At least that was from a couple of sources in the literature that I could find. Comes out to around 3.4 to 4.2 deaths per 100,000 divers. Some of these folks are diving multiple times a year. So from an event standpoint, it's probably more than 100,000. And there are around 1,400 ED presentations annually for scuba related injuries. So honestly, a lot more than I was expecting when I was learning about scuba diving. So it's not super, super uncommon, so to speak. Quick little meme in there. What my friends think I do when I scuba dive. What my mom thinks I do, swimming with the sharks. Society thinking I'm being on Nat Geo out there. My instructor is thinking I'm just a fool in the water, me trying to find Nemo, and then me actually scuba diving in there. All right, so just a quick few resources for you guys in case you ever have patients ask you questions about diving and where to look for resources. The UHMS, the Undersea and Hyperbaric Medical Society, this is a nonprofit org. They're kind of the international experts and kind of primary source for scientific info about diving and hyperbaric medicine. And so they have a pretty good website with a lot of information and references that you can tell patients to look to if they ever have questions. There are a lot of resources like dive tables with a lot of specific information to help you kind of navigate and plan your dives. A lot of dive planning apps available on the phones nowadays. And then some of these apps can help you create things like decompression profiles that help you figure out exactly how long you need to be at each depth when you're decompressing, how long to take stops, that sort of thing to help you safely ascend and descend in the water when you're diving. All right, going into the medicine side of things, I put yellow stars on the slides in this talk that had more high yield information. So when you're looking back and prepping for the CAQ, you can focus more on the yellow star slides and maybe the questions at the end. So it all really boils down to a couple of physics, chemistry related laws that kind of govern everything about diving medicine. So Boyle's law, and I thought I would never hear these laws again after high school and college, and then they popped up and I was prepping for this and I was like, here we go again. Boyle's law, at a constant temperature, the volume of gas and pressure on the gas are inversely related. So the equation's there, P1 V1 equals P2 V2. So as pressure increases, volume decreases. This is what explains things like barotrauma and air embolisms and affects essentially any air-filled cavity in the body. So especially the lungs, the ears, the sinuses. And then you have Henry's law. So this one's a little bit harder to understand, but at a constant temperature, the amount of gas dissolved or the concentration of a gas in a liquid is proportional to the partial pressure of the gas above the solution. And so in that equation, C is the concentration of that gas, KH is Henry's constant, and then P is the partial pressure. And this explains things like decompression sickness and nitrogen narcosis, which we'll get to in the next half hour or so. A couple diagrams here that you can look at for those who are visual learners. So Boyle's law, this kind of schematically shows that as you decrease that volume, that pressure goes up. And one way I like to think about Henry's law is it's actually a good way to explain why your soda cans fizz when you open them. And so when people were making soda cans, you compress a lot of gas under a lot of pressure in a small volume, and that CO2 dissolves in the solution. And as soon as you open up that soda can tab, all that pressure gets released and those CO2 bubbles come out of solution. So that's why you get the fizzing. And so a similar process essentially can happen in the body from nitrogen and oxygen. Quick photo bomb from a shark. So, I always say that the things in medicine that are the scariest are the things that we can't see. And I feel like everything in dive medicine are things that you can't see figuratively and literally. And so it's important to know about some of the more common and dangerous conditions you might come across in dive medicine so that if someone eventually strolls into your clinic one day, you're at least aware of these concepts, I think, and can recognize emergencies when they come up. So barotrauma. Barotrauma, this is tissue damage or injury due to a pressure difference between a space in the body and an adjacent or surrounding gas. You can have barotrauma of descent and barotrauma of ascent, so we'll break those up coming up here in the next few slides. And again, this all kind of relates back to Boyle's law. So going into barotrauma of descent, there are four major kind of categories of barotrauma of descent, at least. I mean, this can affect any air-filled cavity in the body, but the primary ones you hear about are otic barotrauma, sinus barotrauma, mask squeeze, and barodontalgia or dental. So starting with otic barotrauma, this is the most common area for symptomatic barotrauma. It's actually the most common kind of complaint or symptom that divers get in general. It's usually due to that pressure differential. As you're diving underwater, you can actually generate a pretty big pressure differential just 2 to 4 feet below the surface of the water at sea level. And so if you exceed that pressure differential of 60 millimeters, you can block off the eustachian tube, feel a lot of pressure. That can be really, really painful. We feel similar things when we're flying in the sky, but certainly when you're diving, that can happen very quickly, just within a few feet of diving below the surface. This can affect any part of the ear, so the external, middle, or inner ear. If it's the inner ear, you can get kind of more serious symptoms like hearing loss, tinnitus, vestibular symptoms. One thing to note is that inner ear otic barotrauma typically happens while you're diving. If you get symptoms after you surface from a dive, that tends to clue you into more decompression sickness, type 2 specifically, which we'll get to. Typically, you want to avoid diving while you have an upper respiratory illness, just because you're at increased risk for barotrauma. Like I mentioned, there's different types of otic barotrauma. So external ear, where you can get just more hemorrhage and edema in the outer canal. The middle ear, which is the most common diving injury, like I mentioned, happens usually in those first few feet. If you get a sudden relief of pain while you're diving, that might suggest that your TM is ruptured. So important for someone to take a look in that canal and check to make sure you haven't perfed your TM. Sometimes water can rush into the ear. That gives you this cold caloric stimulus and can cause a lot of vestibular symptoms. And then certainly with the inner ear, if your inner ear experiences barotrauma due to that difference of that pressure differential between the middle and inner ear, that can lead to some of those more serious symptoms. They can rupture the oval or round window even. So patients will typically have ear pain, fullness, vertigo, tinnitus, hearing loss. In the middle ear, that's conductive. In the inner ear, that's more sensory neural. On exam, you might see signs of a TM rupture on otoscopy, some edema or hemorrhage in the external auditory canal, And then you want to make sure these patients have a normal neuro exam, even if it's a quick neuro exam, kind of scan on exam, just to rule out infarction, because sometimes those symptoms can overlap. This is typically self-limited, so symptoms get better within a week, sometimes up to 2 weeks, and most ruptured TMs, if you have them, will heal within a few months. But if you have issues, you can send them on your way to ENT. I'm not going to go into this in detail. There is technically a grading system called the TEED grading system out there to kind of grade different degrees of findings with barotrauma. So here's just kind of a diagram showing those different grades. At the end of the day, this is more of a clinical diagnosis, and you should be able to figure it out just from history and talking with the patient. How do we treat this? So the big things are really treating the pain. So if you're while you're diving, you want to stop descending and actually ascend a little bit until that to decrease that pressure differential, relieve the pain, and equalize your pressure before continuing to dive, avoiding some of these risk factors like diving with an illness, smoking, controlling your allergies. So sometimes drops can be helpful. If you have a TM issue or a TM rupture, Ciprodex drops can be useful. If you have hearing issues, sending patients to audiology or sending patients to ENT if they're having issues with healing of the TM. If your inner ear is affected, you want to make sure you're not blowing your nose. Sometimes we use medications to help kind of decrease the inflammation, control the pain. Things like stool softeners are important to consider, for example, to avoid straining. Anyone with an inner ear otic barotrauma should get an ENT consult. There are different maneuvers that divers can use to equalize their pressure in their ears. So we all probably know the Valsalva maneuver. We all also probably know the Toynbee maneuver. You just might not know by that name. I think a lot of people will either pinch their nose shut or just kind of not exhale through their nose and then swallow while they're on a plane to help equalize the pressure when they're flying. There is this weird maneuver called the Frenzel maneuver that I honestly still don't quite know if I can do it myself. You guys can look it up later. It's a little interesting, but it involves making like a T or D sound and then essentially closing your glottis up and using your tongue to sweep air back into the nasal cavity. This is a maneuver that divers should probably learn. Not all divers learn this, but it can be useful for those who are doing deeper dives because Valsalva tends to not be super effective when you get past a certain depth, typically around 30 meters. For patients with otic barotrauma, you want to make sure your symptoms resolve before you go back to diving again. And then historically, inner ear barotrauma patients were counseled to stop diving altogether. There's a paper back in 2014 that created the set of 5 criteria. So hearing loss needs to be stable, no vertigo, reducing risk factors in general for middle ear barotrauma, making sure there's no clear anatomic reason why they're getting inner ear barotrauma, and then making sure you don't have an active issue that warrants surgical intervention. So the next one is sinus barotrauma. Similar concept to otic barotrauma, but this occurs in the sinuses. Like I mentioned, that pressure change is really rapid. And so a 5-meter underwater dive, that pressure change is equivalent to a 5,500-meter descent above sea level. In case someone ever asks you, the frontal sinuses are the ones that are most affected in sinus barotrauma. The pathophys behind this, so going back to kind of Boyle's law, so during descent, that decrease in volume leads to increase in pressure leads to a decrease in volume, and so you get this squeeze effect in the sinuses, creating a vacuum, and so that can pull on and lead to mucosal edema and hematomas, some bleeding. When you're ascending or going up in the water, that decrease in pressure leads to expansion of the gas, and so you get this outward force of the gas, and that can compress the sinuses against the bones. Sometimes it can cause a rupture of those sinuses. In rare cases, you can get a sinus wall fracture or an orbital wall fracture as well. And so patients with that have the risk of meningitis, so one thing to just be mindful of. This is a nice little diagram that kind of shows that. So the pictures on the top show that when you're ascending or going above sea level, you have that outward pressure, so you can have ruptures and tears in the mucosa and compromise in the structure and integrity there. And then when you're descending or going down, those bottom 2 pictures show that inward pressure, so you can get some stripping of that mucosa, some hemorrhage. These patients typically get sinus pain. Unsurprisingly, you can get headaches, epistaxis, so bleeding from the nares can also occur, or expulsion of mucus. Pain is usually the most common symptom. Epistaxis is second most common. I think one thing to be mindful of in case it comes up as a potential board question is patients with sinus barotrauma can sometimes have compression of the 5th cranial nerve, so that trigeminal nerve, and so patients can sometimes get cranial nerve 5 neuropraxia, so associated pain and numbness around the face with that. how to prevent this. So typically kind of like all these issues you want to avoid diving when you have an upper respiratory illness or a sinusitis, trying to avoid vasoconstrictive meds and nasal irritants, learning how to properly equalize pressure with your ears, like doing a proper Valsalva maneuver, Toynbee maneuver, Frenzel maneuver before you go diving for the first time. You don't want diving to be the first time you're trying these things. Diving feet first. And then a couple of papers mentioned the possibility of using pseudoephedrine taken about half an hour before diving or exposure to a barotraumatic event. And that has been shown to reduce the incidence of at least otic barotrauma in up to 50% of patients with a history of barotitis. Similar concept with sinuses as well. For treatment, typically is non-operative, so just kind of conservative management with decongestants, pain control, saline irrigations. Sometimes you can consider antibiotics or steroids for prolonged symptoms. There's no standardized therapy for patients with chronic barosinusitis, and there's really no main role for imaging, although patients with recurrent or chronic presentations, it may be prudent to consider imaging at some point just to look to see if there's anything anatomical that predisposes them to getting these recurrent episodes. There are some operative indications, so you can imagine like more serious complications, abscesses, orbital wall issues, things like that sometimes require surgery, and so there are certain indications for procedures. The next one's mask squeeze. So this occurs because the air in your mask doesn't get equalized with the pressure, and so think of your face getting stuck in a suction cup essentially, and this can create a lot of pressure between the air and the vasculature in your face and lead to kind of bruising, severe discoloration, injury to the eyes even. Here are a couple extreme pictures. Should have given you guys a warning, sorry, but here are a couple of not so pleasant photos of people with mask squeeze. So you can get like conjunctival hemorrhages and petechia. You can see that bruising on the face underneath the eyes as well. And some patients can have it a lot more serious than this too. So patients get redness or engorgement of the blood vessels in the eyes, cheeks, periorbital tissue. Usually the pain's not too bad, and visual disturbances are rare, but a complication to be aware of. It's a clinical diagnosis. It's typically self-limited, gets better within a couple of weeks. Cold compresses can be helpful, pain control. The one thing to know about mask squeeze is that if you're having any like concerning eye-related symptoms like hyphemas, your vision is altered, you have a lot of pain concerning for ocular compartment syndrome, you definitely want an urgent ophthalmology consultation for these patients. Ways to prevent this. So the biggest, most important thing is making sure you're exhaling through your nose consistently as you're diving. And then the last one's barodontalgia. So barometric pressure induced pain in the teeth or kind of around the mouth. This is pretty rare in general. It can be difficult to differentiate from barosinusitis if it's more maxillary pain patients are having. Recent dental therapy or having just underlying dental issues can put you at risk for this. It typically occurs more in your upper dentition, and your upper and lower molars are the most affected. Contributing factors, like I mentioned, dental infections, differences in kind of subtle differences in pressure between the dental enamel and pulp, and that can vary from person to person. It can occur both with descent and ascent. This kind of repeats what I just said, but patients can get mandibular or maxillary pain. They can get tenderness along those areas. The most important thing for patients with this, or even before patients go diving, is just making sure that you have good vitality of all your teeth. If there are dental issues, you want to address them before you go diving. Typically, it's non-operative. You want to get them back to ground level or atmospheric level pressure, restore any curious lesions, kind of defects in the teeth, that sort of stuff. All right, quick break. Did you know that scuba divers roll backwards out of boats because if they rolled forward, they would just go into the boat? This is not actually why they roll backwards out of the boat, but I just thought it was kind of funny. If you're curious, scuba divers actually roll backwards out of the boat to go in the water, mostly to protect their gear. There's a lot of delicate gear sometimes on the front of their mask or their torso, and it's often just to help protect that gear when they impact the water and so that they don't get wires and things like that tangled up. So nothing really special or unique about rolling backwards into the water. All right, barotrauma of ascent. So this is really the crux of the lecture today. Probably the most important things to remember are DCI, so DCS and AGE. So Barotrauma of ascent encompasses pulmonary barotrauma, decompression illness, which we'll talk about. This includes both decompression sickness and arterial gas embolism. I think it's easy to kind of, when you're talking about these two things, they sound pretty similar. The main difference is that decompression sickness typically is referring more to bubble formation in your venous vasculature and tissues, whereas arterial gas embolism, as it sounds like, is where you get gas bubbles in the arterial circulation. There are a couple other things I'm not going to talk about, but you can get alternobaric vertigo, which occurs due to pressure differences between the middle and inner ear. And then you can also get Bell's palsy in some rare instances. So pulmonary barotrauma, this is rapid expansion or compression of air. There's an increased risk with breath holding and rapid ascent. So those are the two key things to advise patients about are making sure you don't breath hold as you're ascending and making sure you take your time and ascend. That's why those decompression profiles can be helpful to make sure that you're doing a proper decompression or ascent. As you're ascending, the alveola can rupture with that gas expansion. And you can imagine, depending on where that happens, as you see in this diagram, you can get things like mediastinal, subcutaneous emphysema. Pneumothorax is one important complication that can happen from this. And then you can get gas embolism too. Treatment is typically supportive, so rest, oxygen, supportive care. Those with a pneumothorax are going to need a chest tube. Decompression illness. So probably one of the most important slides in this talk. So decompression illness, this encompasses both AGE, arterial gas embolism, and DCS, or decompression sickness. I underlined again kind of that key difference in terms of arterial versus venous blood in the tissues to differentiate the two. And this all goes back to Henry's law, that kind of soda can fizzing analogy that I was talking about. So as you're returning to the surface, oxygen and nitrogen are going to be released from the venous blood and tissues, and that can lead to bubble formation. Those bubbles are typically venous. The exception would be really if you have a PFO, which is a consideration that we'll talk about and is definitely a testable concept. These bubbles have a lot of secondary effects in the body. So they activate inflammatory cascades, the complement system, coagulation cascades, cause endothelial damage. So there are a lot of issues that can arise from this. Some risk factors associated with DCS: increased depth of dive, increased time spent at depth, a rapid ascent, our older patients, and being dehydrated. For DCS, typically your onset is 1 to 24 hours. This is important because it really helps differentiate this from AGE. AGE is really the most feared complication or problem from diving, and AGE typically presents within minutes or almost immediately from after surfacing. DCS is typically classified into two types, types 1 and 2. Type 1 is the milder type. This is more your MSK system, the cutaneous system, whereas type 2 is more severe and can affect your other organs, such as your lungs, lead to neurologic symptoms. In type 2 neurologic decompression sickness, over 50% of patients will get symptoms within an hour. So you can typically present much more quickly. Within 6 hours, 90% of divers are symptomatic, but it's generally not like within a couple of minutes, like you see with that arterial gas embolism. So DCS type 1, this is that musculoskeletal and cutaneous type of DCS. This is the more mild form. When you hear people talk about the bends, this is what they're talking about. This makes up about 70% of DCS. It can be associated with pain around the joints, but typically patients do not have a joint effusion, so they should not have an effusion on exam. You can get skin changes, pruritus, cutis marmorata. Typically presents within 6 to 8 hours of surfacing. The vast majority will present within the first day after surfacing. Interestingly enough, one thing that you can do to help differentiate this from other types of musculoskeletal pain is insufflating a blood pressure cuff to a pretty high pressure around the affected joint. Patients with DCS typically report a lot of pain relief with that insufflation. Treatment for this, as is with a lot of these dive medicine related problems, is kind of conservative. These patients, you need to give them hyperbaric oxygen therapy. That's important. Essentially, they are ascending too quickly or too rapidly, and you need to get them in a chamber, essentially recompress them kind of back to their previous depth, and then slowly and gradually decompress them and gradually change the pressure so that these bubbles aren't forming as quickly, violently, prominently. The one complication to be aware of with DCS that you can be tested on is osteonecrosis. And so if these gas bubbles, depending on where they go in the circulation, can essentially cause an avascular necrosis. typically seen most in your longer bones. So your humerus, your femur, and your tibia are the three most common bones you typically see this osteonecrosis in. Here's a nice little diagram you guys can look at again later, just for more visual learners about just reiterating all those things I talked about. And then here are some of the skin changes and cutis marmorata changes that you can see with DCS. DCS type 2, so this is the more serious type of DCS, can affect the pulmonary system, can lead to vestibular and neurologic symptoms as well that I've listed there. Essentially anything neurologic you can think of, you can pretty much have with this. Patients will often present in the first half hour. Most of them will present within the first few hours. There is an increased risk, if you have a PFO or a patent foramen ovale. There are many different colloquial terms depending on what's affected. So if it's the pulmonary system, it's called the chokes. If it's in your vasculature, they call that, you can get decompression shock. That typically has a bad prognosis. Like I mentioned before, when talking about otic barotrauma, you want to differentiate otic barotrauma, which is pretty self-limited, and you don't really have to do much for that, versus inner ear DCS type 2. Again, the main difference is that otic barotrauma you're going to experience while you're diving, whereas DCS is something that occurs after you surface. So these patients are going to have maybe an overlap or similar symptoms from a vestibular neurologic standpoint, but typically they occur after you surface. One important thing to note is that you can get brain DCS if the bubbles get to the brain. And so brain DCS is really hard to distinguish from AGE. As I'll talk about with AGE, loss of consciousness is that big tipping point. So any patient with loss of consciousness, you essentially want to assume that they have an arterial gas embolism until proven otherwise. For diagnosis and treatment, early recognition is important. ACLS if needed, 100% oxygen. To basically help them oxygenate better. You want these patients to be horizontal. You don't want them Trendelenburg. A Trendelenburg position increases the risk for cerebral edema and other issues. So you want them horizontal. Rehydrate them if they're dehydrated. NSAIDs if not contraindicated to help control pain. And then the definitive treatment for patients with DCS is hyperbaric oxygen therapy, specifically in a hyperbaric oxygen chamber if you can. And so the idea behind that is really recompressing them to help eliminate those bubbles and dissolve the gas. You want to increase the oxygen delivery to the body with that 100% O2 and then gradually decompress them in a controlled setting in that chamber. Important to rule out pneumothorax before you do this. So if they do have that present, you want to place that chest tube before you stick them in this chamber and have them suffer from a pneumothorax for a prolonged period of time, because that would be bad. Risk reduction, the three key things. So you really want to just avoid breath holding as you're ascending, avoiding a rapid descent, and then, like I keep mentioning, try not to dive with an active pulmonary infection or disease. All right, arterial gas embolism. So this is the most feared complication of divers. This occurs because air enters the circulation from the pulmonary capillaries, goes to the heart, and then goes to your arterial circulation. A large proportion of air bubbles can get to the brain. That can happen very quickly, obviously. And if that happens, you essentially have occlusion and a stroke-like episode. So the most common symptoms and signs are typically neurologic, and they can basically present like a stroke. Almost 2/3 of patients get alterations of consciousness. They may not have like a complete loss of consciousness, but most of them have a pretty significant alteration of consciousness. Like I mentioned, LOC is essentially AGE until proven otherwise. They can appear and mimic DCS type 2, and so they can look very, very similar. So if you're worried or kind of not sure which one it is, err on the side of caution and presume that it's AGE. There's this phenomenon that some of these air emboli might partially clear, and so patients might show initial improvement, but you shouldn't let your guard down and assume that means that they're going to get better on their own. So again, just a list of kind of all sorts of neurologic symptoms. Of note, you can get cardiac arrest from this, so should be prepared to kind of go through ACLS protocol if need be. Typically presents immediately upon surfacing, so within 5 to 10 minutes at the most. So this is really the big key differentiator between AGE and DCS, is how quickly that these patients get sick or look sick. The treatment is the same essentially though, so 100% O2, chest tube if they need it, hyperbaric oxygen therapy. Typically, you don't need labs or imaging to help diagnose this. I threw this slide in there just in case, like, you want to reference and someone someday asks you about labs and stuff. There are certain lab findings you might see in AGE. You don't need to get a chest radiograph on this. You want to rule out things like a pneumothorax, and then a head CT doesn't help you make the it can help you make the diagnosis if you see signs of air bubbles essentially in the circulation or on CT of the head. It can help you rule out intracranial hemorrhage, but you don't necessarily need the CT to make the diagnosis. And a key thing is that normal head imaging does not rule out HEE. So this is a pretty extreme example of what a advanced imaging of the brain can look like when you have these gas bubbles. You can see just kind of how profound and diffuse this brain is affected. So treatment, supplemental oxygen. Again, you want these patients to be supine, not in a Trendelenburg position because of the risk for cerebral edema. Some people have this thought that putting you Trendelenburg helps you with the air bubbles because they'll like rise. That's not true. If you're in an aircraft, you want to pressurize the aircraft to sea level or decrease your flying altitude to a lower altitude. And then again, kind of like DCS, the main treatment is hyperbaric oxygen therapy. Here's a nice little diagram that kind of shows it too. This doesn't really make it super clear that you see DCS more in that venous vasculature and in the tissues. But again, that's really the big differentiator is formation of those bubbles from nitrogen and oxygen in the venous system and tissues in DCS versus arterial bubbles in AGE. This is a table you guys can reference later on. I just found this online. It kind of covers a little bit of all the different things you can see in dive medicine in terms of problems and breaks it up into a nice little table. All right, some other injuries you can see at death. So I'll cover a few of these pretty quickly. So immersion pulmonary edema, or IPE, sometimes referred to as swimming-induced pulmonary edema. You can think of this as like when we're out in the cold, your body's going to shunt all the blood to your core to help protect your brain and your heart, which is obviously important. And at the extent of kind of sacrificing your peripheral extremities, a similar thing basically happens in the water. So your body redistributes peripheral blood to the central circulation. You get peripheral vasoconstriction, and so this can end up increasing your pulmonary vasculature blood volume, increasing your cardiac output, increasing your pulmonary artery pressures, and can lead to a number of pulmonary symptoms, just like a patient who has pulmonary edema from other causes. So they can have dyspnea, cough, hemoptysis. Older patients are at risk for this. Females, you see this a little bit more in hypertension, NSAIDs before diving, and then deeper dives. Patients who also hyperhydrate before they dive are at increased risk for this. Clinical features. So one key thing, these patients haven't had a history of aspiration or laryngospasm. It typically happens pretty quickly after immersion. The vast majority of patients will have cough. About half of patients will have hemoptysis, and they're going to have essentially a variety of different cardiorespiratory symptoms. On exam, their SpO2 is going to be decreased. Sometimes you can hear an S3 gallop, and if you were to auscultate them, you may hear crackles, rales, or rhonchi like you would with patients with pulmonary edema from other causes. Workup-wise, chest radiograph initially might be normal, but later on you might see some of those typical findings on chest x-rays like interstitial edema, curly B lines, some ground glass opacities. If you get a blood gas on these patients, you might see an increased AA gradient. Some cardiac biomarkers might be elevated as well. Management for these patients, so typically it's supportive. You want to get them out of the water, get them out of the cold, get them warmed up essentially. Albuterol can sometimes be helpful. You want to give them O2 to get that SpO2 level back up to a safe zone. Sildenafil can be helpful to address the pulmonary artery pressure issue. And overall, IP is pretty self-limited, typically resolves within 1 to 2 days. All right, gas toxicity. So there are a few different gas toxicities to be aware of. This kind of goes along with Dalton's law, the third physics chemistry law, which is that total pressure exerted by a mixture of gases is equal to the sum of partial pressures of each gas. Patients with gas toxicities will present like their brain is the size of like a walnut, essentially, like figuratively, like you see in Homer here. So oxygen toxicity, this occurs as you're breathing in oxygen during your dive. There are different partial pressure ranges that you can find online. You don't need to know these numbers, but there are different kind of green, yellow, red light zones for kind of danger zones for oxygen partial pressures that you should be inhaling. These patients get a lot of tracheal bronchial symptoms initially, and then after a while of oxygen toxicity, start to get more CNS symptoms. A lot of divers use nitrox, which has a higher oxygen percentage. That's typically the most likely culprit in recreational divers. They use nitrox because that increased oxygen allows them to have more time with diving, more bottom time at the bottom of their dive. But if they don't kind of follow protocol or guidelines, they're increasing their risk for oxygen toxicity. Um, like I mentioned, a lot of tracheobronchial symptoms initially, and then progresses to more neurologic symptoms. Physical exam wise, you want to make sure you have a thorough neurologic exam. Patients might have shivering, twitching, some tonic-clonic activity. Seizure is kind of the one main differentiator or present or kind of symptom finding that you'll see with oxygen toxicity when it gets more severe. Treatment wise, you want to control their ascent in the water, reduce their exposure to increased oxygen levels, and do this gradually. Some patients are going to require hyperbaric oxygen therapy. You might want to include anti-epileptic medications to prevent the risk of seizures in these patients at times. And then it's important to take these things called air breaks, which basically allow them to intermittently air breathe while they're in the hyperbaric environment. These have been shown to decrease oxygen toxicity by a pretty big factor. A lot of the times patients with oxygen toxicity need admission to the hospital just because of the amount of time it takes to kind of resolve their symptoms, and then the supplemental oxygen that they need, as well as just continued monitoring. Nitrogen narcosis is the other major type of gas toxicity to be aware of. So this occurs from inhalation of compressed nitrogen at depth, typically develops around 100 feet of depth. Divers can develop tolerance. The way I describe nitrogen narcosis is it's basically like a drunk person who's had a ton of alcohol. They present super similarly. Funnily enough, alcohol is a risk factor for nitrogen narcosis. The guy who made the aqua lung had this fun little quote back in the day that said, "The chief symptom of nitrogen narcosis is, to put it bluntly, the sensation of becoming as drunk as a hoot owl." So these patients typically present insidiously. Early on, you get a sense of euphoria, impaired judgment. Later on, you start to get some more serious symptoms like impaired concentration, hallucinations, eventually get loss of consciousness. Symptoms are pretty self-limited, typically resolve upon surfacing. Patients often have a fairly normal physical exam as well. And you just want to control their ascent so you don't cause things like decompression, illness, or other complications as well. Reduce that partial pressure of the dissolved nitrogen as they're resurfacing. And you typically don't see any long-term consequences, just like you don't hopefully see long-term consequences from someone who drinks too much alcohol. Typically, these patients don't have to be hospitalized for monitoring. And then the last one, this one's not as common, but you can get carbon monoxide toxicity. This can occur if your gear gets faulty or if there's a ton of exhaust nearby in the water from things like petrol engines. You see this more in sport divers. During descent, symptoms can be particularly rapid and severe. Here's a little diagram that just shows that essentially carbon monoxide can affect all your major organ systems in the body and can be pretty bad, pretty lethal. From presentation, you can get a wide spectrum of symptoms and features spanning all your body systems, essentially. Really important to perform a thorough neurologic examination if you're concerned for carbon monoxide toxicity. If you might recall from back in the day when you learned about this, you want to have a high level of clinical suspicion for this. And carboxyhemoglobin registers the same as oxyhemoglobin, and so you might have an artificially high SpO2 if you were to check an SpO2 level. So don't get tricked by that. Co-oximetry and a BBG can be helpful for differentiating. Treatment. So these patients can get really sick really fast. So you want to do your ABCs, give them oxygen therapy until their carboxyhemoglobin level gets below 10%. Even after they get below 10%, there's still some anaerobic carbon monoxide metabolism happening. And so you still want to treat them for a few hours after you hit that 10%. You don't want to stop right away. There are certain indications for hyperbaric oxygen therapy. I don't think this is going to be really real CAQ testable information. So I'll just leave this slide here to look at later if you're interested. So prevention of gas toxicities, really you want to avoid diving super deep. You want to try to use a nitrogen-free gas mixture such as Heliox, for example. But again, you want to just make sure that you're, like for oxygen toxicity, making sure that you're not using too high of a concentration of oxygen or that you're not spending more time than you should at depths. Checking on your diving companions, making sure that your tank is working properly, that your dive shop that you go to test your gear and test your gas for carbon monoxide in your tank. All right. There's this concept called caustic cocktail. So this occurs when water enters a closed circuit, mixes with this material called soda sorb that we use in diving, and becomes highly basic. And so patients can essentially get a burn to the throat in the GI tract, like if they were to consume some super strong base. Soda sorb, also known as soda lime. So we use this in closed circuit rebreathers, helps to remove the carbon dioxide from the circuit. So it's very helpful in that sense. But if anything happens to your circuit and that soda sorb gets in contact with water, it reacts and immediately becomes very, very basic and caustic. And so you can imagine if you inhale that while you're underwater, you can get some pretty severe liquefactive necrotic burns and mucosal lesions. You can get scar tissue and strictures like you would imagine with any other type of caustic burn in the esophagus and GI tract. And so patients are going to have odynophagia, trouble swallowing, pain with deep inspiration. You might be spitting out sputum because of the pain, have stridor and coarse breath sounds. If you're to EGD these patients, you might see erosions. You might see that on bronchoscopy as well. Treatment. So this obviously happens while you're diving. Like if something happens to your gear and the soda sorb reacts with the water that you're diving in and you inhale that in that split second, you're going to get this. So the gold standard first aid treatment that divers should be aware of is to immediately flush their water repeatedly with flush their mouth repeatedly with water, preferably fresh water, although you don't really have control over that depending on where you're diving. No other treatments are really available when the diver is underwater, and then you need kind of typical medical evaluation when you resurface. So just try to flush your mouth with water as best as you can. All right, some other considerations. So just from an injury prevention standpoint, you want to make sure patients have a good history and PPE before they dive. You want to make sure they can Valsalva, that they're fairly fit. You want to make sure that they know how to equalize their ears upon entering the water and have at least some familiarity with decompression tables and some of these apps and resources that help them prepare for dives. Trying to avoid breath holding during ascents, and if you can, trying to avoid diving alone. There are different checklists that divers can use to inspect their equipment before diving. We typically warn divers against multiple daily dives or diving and flying on the same day. Having a good dental evaluation if there are concerns for vitality of the teeth or dental caries, things like that. Something that sometimes gets asked about is flying after diving. So the DAN, or the Divers Alert Network, I think Sue's mentioned in the chat that they're a good resource as well for kind of dive medicine. They have a lot of good infographics on their website as well that are both educational for providers and patients. They have these consensus guidelines about flying after recreational diving. Typically, if you have a single no decompression dive, you can fly after about 12 hours. If you've dived for multiple times in one day or for multiple days in a row, you want to wait 18 hours. And then there's this quote of waiting substantially longer than 18 hours appears prudent for those who need to do true decompression dives. This graphic I found on the DAN website mentioned 24 plus hours. So from what I could read online in other papers, it seems like 24 plus hours is the standard for that. Patients with pulmonary disease should be screened. There are other conditions that we'll get to in the next few slides as well, but there are a lot of different pulmonary conditions, so you want to kind of screen these patients for sure before going underwater. I think I've been alluding a lot to making sure there's no active respiratory illness or respiratory infection while you're diving. From a comorbidity standpoint, hypertension is a really common one, obviously, in our population in the US. And so that increased volume of central circulation can increase the risk of central hypertension and immersion pulmonary edema. From a medication standpoint, ACEs and ARBs are typically preferred. CCBs, diuretics, are less preferred. Beta blockers are also typically not preferred, although depending on how well controlled you are and in the appropriate setting, there are some divers who do take beta blockers that are allowed to dive. Coronary artery disease, or CAD. So diving essentially introduces a lot of different stresses on the cardiac system, including increased myocardial oxygen demands, preload and afterload stresses as well. Divers over the age of 40 typically should undergo a risk assessment for coronary artery disease. If you're having symptoms, you need evaluation. Typically, we don't screen younger, healthy patients who don't have major risk factors for cardiac disease. There are different thresholds there for optimal fitness to dive that you can learn more about in your free time if you're really, really interested in that. And then typically patients getting treatment for coronary artery disease, you should make sure that they have about 6 to 12 months of stability and cardiac rehab if needed after after procedure before returning them to sport. PFO, so this is a really testable, easy testable question. So, I mean, 25% of the population roughly has a PFO, so they're super common. There's an increased risk of DCS in divers with PFO. So many studies have been done over the past 20 to 30 years with odds ratios ranging from 2.5 upwards to 25 for the increased risk of DCS in patients with a PFO. And then you have to remember that if you have a PFO, a bubble from the venous system can easily get to your arterial system and then cause an arterial gas embolism. And so just being mindful of those complications and extra mindful of patients with PFOs. PFO is not an absolute contraindication for diving. So you can have a PFO and still dive. You don't necessarily even have to screen recreational divers for these. But typically, if you have a PFO, you try to recommend avoiding decompression dives and doing all the typical things to reduce your risk of getting complications from diving. Asthma is another important comorbidity and consideration. So would be really bad to have an asthma attack while you're diving, and cold and exercise are triggers for many asthmatics. And so the general consensus, there's a lot of text on here that I'm not going to read, but essentially the crux of it all is you want to make sure that you have normal lung function. You want to make sure that your asthma is well controlled, that if you're on medication that you've been stable for a while. The guidelines really vary from region to region and country to country. So there isn't really any great set standard for this, but essentially you want to make sure your asthma is well controlled. You can do spirometry and make sure that your FEV isn't below 80%. And then if you're using your rescue albuterol inhaler, you want to make sure you haven't needed that in the past 48 hours prior to diving. Diabetes is super common. So obviously you run the risk of hypoglycemia when you're doing any sport, including diving. And it would be really bad to have a hypoglycemic event while you are 100 feet underwater. And so these patients are typically held to high standards of fitness. You want to make sure they're very experienced in their diabetes management and haven't had any hiccups recently. Typically exclude divers who've had systemic sequelae or major complications from their diabetes in general, patients with a recent history of hypo or hyperglycemia that's uncontrolled, or just poorly uncontrolled blood glucose. The DAN guidelines, typically, these were from back in 2005. I think they just released some newer ones in the past year, but I couldn't find a good kind of graphic for it online. But back in 2005, the guidelines stated that you needed an A1C under 9%, had to be stable on insulin for a year or an oral hypoglycemic agent for 3 months, not had any significant episodes for the past year, no major secondary complications, and then you want to make sure you don't have hypoglycemic unawareness. Geriatric patients. So aging adults are doing more and more exercise nowadays, including diving. And so you may be asked to evaluate some adults or geriatric patients one day who want to see if they are fit enough to dive. Or have at least a friend ask you about it. And so there's no formal age limit for recreational scuba diving. It really just varies person to person depending on their kind of overall health state, what kinds of acute and chronic illnesses they have, fitness. So screening for things like coronary artery disease, hypertension, diabetes, etc. You may want to consider less rigorous diving programs for these patients. All right, last couple of slides. So there are some absolute contraindications that you need to be aware of. So this is very testable CAQ information. So the biggest absolute contraindications are a history of a spontaneous pneumothorax or pulmonary blebs. These patients are at increased risk for having a tension pneumo while they're underwater. Patients with asthma with an FEV1 less than 80% of normal. Hence why I mentioned that spirometry can be helpful and important in patients who don't have well-controlled asthma. Pregnancy is an absolute contraindication of diving. Coronary artery disease that is symptomatic. Anyone with a history of epilepsy or a poorly controlled seizure disorder, even if they are well controlled, epilepsy is still contraindication because you run the risk of having a seizure while underwater. And if that happens when you're 100 feet underwater, you are basically dead. Active eustachian tube dysfunction or TM rupture. And then patients with high uncontrolled blood pressure, so typically systolic blood pressure over 160 millimeters of mercury. There are some relative contraindications as well. There's actually a big long list on the UHMS and DAN website that has like 100 things really, but essentially some of the bigger ones are COPD, previous decompression illness, history of stroke, severe reflux because of the risk of aspiration, patients with a myringotomy and untreated panic disorder. You wouldn't want a panic attack while underwater. Back in the day, some of these were absolute contraindications. They've been switched to relative contraindications. So again, you just want to have good health assessments, make sure that these patients' medical conditions are well controlled and that they understand the risks associated with diving. All right, question time. I think we have a few minutes still. So just a few questions to kind of go over some of the concepts covered in this talk. So question one, I guess I'll ask the fellows or anyone who wants to chime in to maybe jump in and answer. But question one, which of the following gas laws best explains the mechanism of middle ear barotrauma during descent? I'm not going to call on anyone, but if anyone wants to chime in. Otherwise, I'll just say the answer after a few seconds. No, I feel like Cody's unmuting or someone.
Boils, isn't it?
Yeah,
Yeah.
I want to go Boils, but I don't want to go out on a limb.
You got it right. It is Boyles. Your high school chemistry skills are up to par. Good work.
Sweet.
You guys should know. So this is actually one of the ones you should know for the test. Each one of the laws and which illness it relates to. So this question is actually important.
Yeah.
Well, I couldn't remember the other one. What was the second law we went over?
So Boyle's law, that's like the P1, the pressure and
Right.
volume one, how they're inversely related. So this is really barotrauma. Henry's law is the other main one. That's the one that involves like concentration of your gas as it dissolves. That's like that's the whole like soda fizzing concept, and that's how you get bubble formation for things like DCS and
So Boyles and
HDP.
Henry's. Okay.
Boyles and Henry's are probably the two important ones that you could get asked about, I would say. All right, question two. A diver complains of a pruritic skin rash, fatigue, and joint pain several hours after surfacing. There's no neurologic or respiratory symptoms. What is the most appropriate next step? Any takers?
I hate to be too much of a thief. I mean, to me, with the rash and the joint pain, a few hours, it seems like we're kind of talking about some like decompression on the illness. So for me, I mean, I think administering oxygen and arranging hyperbaric treatment just to prevent some of that osteonecrosis or
exactly.
condition seems reasonable.
Yeah, I think that's like one key takeaway from this whole talk is like if you have anyone you're concerned about DCS or AG, just any kind of decompression illness, the most important thing is to give them oxygen and get them hyperbaric therapy right away. A lot of the times, like you'll read stuff about people checking labs and imaging and stuff, like you don't actually have to do that to make the diagnosis. It's all clinical, so you want to just treat them right away. Question three, which of the following symptoms is the most specific for CNS oxygen toxicity during a dive using unenriched oxygen mixtures? There's a lot of extra fluff in the question, but. So this one is generalized tonic-clonic seizure. So the hallmark seizures are the hallmark of CNS toxicity, CNS oxygen toxicity. So that's just kind of the one. I think I mentioned that during the talk briefly, but just one thing to be aware of. Question four. I tried to make this really complicated just to throw people off, but hopefully you can still figure it out. So question four, which of the following patients should not be allowed to dive? An 18-year-old with mild intermittent asthma who had a cold recently and needed albuterol 3 days ago. A 44-year-old female with diabetes on metformin, but has an A1C of 8.5%. A 26-year-old male with a history of a spontaneous pneumothorax that was 3 years ago, treated with a chest tube and pleurodesis, but he's since been asymptomatic and he's been active with sports since then. And a 56-year-old female with a history of hypertension switched recently to a calcium channel blocker. Her recent highest blood pressure was 154/98.
C?
Say that again, Jack?
I said C because I remember A, you said albuterol use is like 48 hours, B,
Yep.
A1C is 9, and then D is 160 for
Yep,
blood
you got
pressure.
it. Perfect. Yep, so spontaneous pneumothorax is an absolute contraindication regardless of how you've been doing since then. Question five, a 32-year-old recreational scuba diver surfaces rapidly after a deep dive. Within minutes, he becomes confused and loses consciousness. What is the most likely diagnosis?
The arterial gas embolism.
Yep. So, I don't know why I highlighted both. That is my fault with my PowerPoint editing animation skills. I'll fix that before I send this out. But yeah, it is C, arterial gas embolism. So, this again, this presents rapidly, like within a few minutes after surfacing. And so if someone gets neurologic symptoms rapidly after surfacing, it's AGE until proven otherwise. If you have loss of consciousness, it is also AGE until proven otherwise. And these patients, you want to get hyperbaric therapy, oxygen right away as well. 26 or 28-year-old presenting to the ED 2 hours after scuba diving to 100 feet of depth. He reports joint pain in both shoulders, generalized fatigue, and an itchy rash on his trunk. He denies confusion, paresthesia, chest pain, or trouble breathing. His vital signs are stable. His exam shows a mottled rash on the abdomen, but has a normal neurologic exam. What is the most appropriate initial management?
I mean, I want to say B. I feel like I don't want to reuse the same answer, but I feel
Yep,
like
it
it's
is
kind
just
of
like the
same
other question. Yeah, I'm
situation.
just trying to hammer home the point. Yeah, so
B for the
again, like you're
bends.
having cutis murmurata, signs of decompression illness, so high flow oxygen, hyperbaric treatment. Question 7, a 40-year-old recreational diver with a history of well-controlled asthma is evaluated for medical clearance to dive. He's had no recent exacerbations and normal spirometry with no bronchial hyperresponsiveness on methacholine challenge. Which of the following is the best recommendation regarding fitness to dive?
Go with B.
Yep. So this patient has had good control with his asthma. He's had recent normal spirometry, so he is clear to dive. If he had abnormal spirometry or an FEV1 below 80%, or had poorly controlled albuterol or needed it within the past day or two, those patients should not be diving. Question 8. Got a couple more, sorry. Almost done. 45-year-old diver with well-controlled epilepsy on a single anti-epileptic medication asks if they can safely dive. What is your recommendation?
Hell no.
No.
Yeah, so let's see. Diving is contraindicated in individuals with epilepsy. Even if they have the best controlled epilepsy in the world, you do not want someone having a seizure while they are underwater. Question 9, a diver experiences shortness of breath, hemoptysis, and chest pain shortly after a deep dive with rapid ascent. His oxygen saturation is 84%, and chest x-ray reveals diffuse alveolar infiltrates. What is the most likely diagnosis?
I mean, I'm gonna go on a limb here.
A.
I'm gonna go A. Yeah, I feel
Yep,
like
that's
mostly
right.
off
Yep.
of the chest X-ray. I
Yeah,
feel
so
like if
these,
you didn't give
yeah.
me the chest X-ray, I'd be like, I don't know, man. It could be both.
Yeah, so I think the key is, you have a diver, they're getting these respiratory symptoms like hemoptysis, so dyspnea, cough, hemoptysis are the most common ones. Their O2 sats down, and chest x-ray findings, which aren't going to be immediate necessarily, but if you have findings that fit along with pulmonary edema, it's emergent pulmonary edema. All right, question 10. 35-year-old commercial diver experiences sudden onset left-sided weakness, vision changes, and slurred speech within 5 minutes of surfacing after a rapid ascent. Which of the following findings would best support the diagnosis of arterial gas embolism?
Is it D?
It's not D. I threw that in to kind of
Uh,
trick. So D is true,
I
but it is.
Tricked.
I mean, on B, you have air in the circulation. So I think I would have said D too, because I would have gotten tricked, but maybe backup option being B, just because you're describing air.
Yeah. So I mean, B, if you see evidence of air, like if someone were to image and you see evidence of intravascular air in that cerebral circulation, kind of like that one image I'd showed to that CT scan, like that supports the diagnosis of AGE. But you are correct, Helene, in that if you have neuro imaging, it does not rule out AGE. So that is important. All right, bonus question, and then we're done. So 23-year-old healthy male scuba diver surfaces without issue after a recreational dive. 1 hour later, he experiences bilateral leg weakness and urinary retention. Neurological exam reveals decreased sensation below the umbilicus and hyperreflexia. What is the most appropriate next step?
I'm gonna guess C, but
Yeah.
Yep, that's right. So it's just me kind of hammering home this concept. So this is spinal cord decompression illness.
Ah.
It's a medical emergency, but you don't want to delay treatment for imaging. So you do want to start these patients on high flow oxygen and hyperbaric therapy right away, while you're still doing all this other workup too. All right, that's all I got. Scuba scuba doo. Hope you guys learned something from that. I'll send these slides out to Sue so they can get them out to all of you after I fix that one little animation mishap. There's some extra information in kind of the footnotes in this on some of the slides, and I know there are a lot of walls of text that I didn't read through, but that information is just there for you to reference if you ever need to reference some info about dive medicine. But hopefully the questions in the yellow starred slides will kind of point you to some of the key concepts. I think biggest things like differentiating like otic barotrauma from DCS type 2 of the inner ear, knowing the difference between DCS and AGE, recognizing that oxygen and hyperbaric oxygen therapy is kind of that first line treatment for a lot of these issues, and that there are things that divers can do to help decrease the risk, like not ascending too quickly, not holding your breath while ascending, things like that.
As the person who's most recently taken the stupid test, I can tell you one, Kevin has done you all a great service with this talk. That you do not need to know anything more than what was in this talk. So you guys should all thank Kevin. I think he deserves a beer or whatever it is that he drinks for making this talk for you guys. The things that I remember being important on the test are what Kevin went over. So one, the answer is almost always hyperbaric oxygen, like right away. So the fact that he made that to answer to 3 questions should help you guys out. 2, knowing the timeline, like that the AGE is immediate and the other ones are later. Know the absolute contraindications versus the relative contraindications, and add pregnancy to absolute. You're not supposed to dive while pregnant because of fetal issues. Particularly,
I think he had that one on there.
Yeah.
I think it was on there.
My phone went out a couple times, so I might have missed that one. Particularly, and occasionally this comes up, if your job requires you to dive, even to short, like low distances, you're still not supposed to do that if you're pregnant. So if your job requires you to dive, even low depths is not good, but probably for if you're going to do it once, like a low depth that doesn't require decompression is probably okay, but you should still answer they're not supposed to do it. And then knowing which law relates to which illness, like you don't have to know the formula, but just which law explains which illness. And I remember there being I think I had a question on barotrauma on my exam, and you had to recognize it was barotrauma first and not one of the other illnesses. And then I think the question in the end was how to prevent it. So knowing those prevention things that Kevin brought up are super important.
The way I remember it is just like B for boils and barotrauma. That's probably how I'm going to remember it. It's like a pretty easy way.
Thanks, Kevin. Great talk. My one thing I'd say, like in the beginning, I thought some of the, like if you're looking to trim down, a couple of the ear slides I thought got really redundant. Like you could probably trim down a little bit there. And then I thought your redundancy became much better as the talk went on, actually. But it's obviously, I mean, it's a long talk, which is totally fine. Just be mindful if you're giving it in a group, you always want to, like to learners especially, like make sure you're leaving time for questions for people to ask at some point. And then I added the Divers Alert Network info because they actually can provide you as a physician with consultation. So if you're ever in a situation where you're either the patient with a dive injury or a physician trying to manage a dive injury, you can call them and they actually provide emergency care and consultation over the phone. And then you can ask me and Mandy combined, how many dive medicine issues have we treated in the last 20 plus years? Mandy, what's your total? She hop off. My total is 0.
I have done 0, though I did get a question once in clinic from someone who was going to Mexico or something. I don't even remember what the question was. but I have received one question in clinic regarding diving and the safety of diving around something. It might have been asthma. That's probably the most common one.
Yeah, I would say I've had more questions about altitude than diving, and I think it's probably like 3-0. And
Yeah. I
The
mean, a lot of
other
these
thing-
patients are like going to the ED and not your sports clinic. I mean, maybe Killian will see one eventually from someone doing some stupid diving.
yeah,
like
it just
the-
depends where you practice
Yeah.
too,
I mean,
right?
Jack
Like,
might see some out by like Santa Monica, LA, like at some,
yeah,
who knows?
like, he's
Cody, if
much
someone
more
decides to
likely.
jump in some crazy lake in Alabama, I mean, I don't know.
Yeah, or travel related, right? Some guy's the idiot who, dives and flies home.
Yeah.
That was the other thing. That question has come up on the test of people not doing multiple dives a day and not flying out the same day that you're diving, and people do it all the time. People fly the same day as diving all the time.
Because if you're a diver, why would you sit at a resort when you're not diving? Right? That's how they look at it.
All right, they'll purposely book a later flight so they can get a dive in on the last
Yes.
day.
Yep.
Where's the nearest hyperbaric chamber?
There's one in Cleveland.
I'm sure we probably have one somewhere at our hospital.
do.
And I'm sure the Cleveland Clinic does too.
Yeah. There's definitely one in Cleveland. Ask Cup. Cup will know the answer to this.
There's also one in Toledo.
All righty. Thanks, guys. Have a happy Friday and a good weekend. I
Yeah.
will see you guys later.
Enjoy your long weekend.
Oh, yeah.
It's awesome, Kevin. Thanks.
Yep. Thanks,
Yes.
Kevin.